Good afternoon, everybody. I think it's 5 o'clock. I think we should start and get the show on the road. I'm very pleased to welcome today Dr. Dean Nolte from Gauteng, Nelson Mandela Children's Hospital. He's an anaesthetist in Nelson Mandela Children's, and he's going to talk to us today about pain management and procedural sedation. And then after that, we've got Sr Angie Skrikker from Red Cross Children's Hospital, and she's part of our pain team. And she's going to talk to us about complementary aspects of pain management, all the non-pharmacological things that we often forget about when we deal with pain management in children. So thank you to our two speakers and welcome everybody for joining us. I'm going to ask you just to check that your speakers are on mute, that we don't interrupt our speakers when they talk. And then I'd also like you guys just to type any questions in the chat box along the way, if you think, and if there's something coming up. So let's start with Dean Nolte. Dean, thank you very much. Can you share your screen?
Okay. So thank you for all joining this afternoon. I thought this initially was like a little bit of a small, thought with some registrars and private pediatricians, and then I was told by three of my work colleagues that it was actually the whole society of pediatricians. So I was like, whoever rocks up, that's fine. So I'm going to talk a little bit about pediatric sedation for procedures and just touch on some of the aspects of pain control and pain management. A lot more of this is about just safety aspects and thought aspects around what we do, and just really how we can make sure that, number one, we're actually giving some sort of sedation, analgesia, amnestic agents, and number two, that we are actually, that we know what to do safely, and that we're not just kind of flying by the seat of our pants and not really concerned about what the outcome potentially is. So I like this picture purely because it gives some sort of perspective, and as Barry failed to mention is that I trained in Cape Town and then moved here 2.5 years ago, much to the chagrin of many people and absolute horror. Why would you come to Joburg possibly? So the bottom left is the entrance of Nelson Mandela Children's Hospital. It's a really wonderful place. Space. And then the others are, the top one was actually what the view was during lockdown, severe lockdown, where a few of us would go running in the evenings to just kind of clear headspace and live and breathe. And the bottom one is my normal running route, so just a view of Zoo Lake when it was clean. So when it is clean, it is not really summer. Only disclaimer, I have absolutely no relationship with any pharmaceutical company. So if I say something about a drug, it is just because I potentially like using it for patients or because I do or don't. So that's the first one. Second one is that some of the views that I'm going to express are a merge of some of my ideas, speaking to some of my colleagues, and then also based on some science, although we know that a lot of drugs that we use in pediatrics are off-label, sometimes not even licensed, but that is becoming less common. And also some of the input from, I would say, my grandmasters, so people that I trained from and learned from, and notes and things that I've read from them and gleaned from them. The goal is not that you necessarily feel like I'm shoving something into your head and you are, just make that go away, that you think, oh, I already learned all this stuff, I don't need to know anything more, please don't tell me something that's new, or potentially that you, so it's really to emphasize that we can make it as safe as possible. And then also just talk about how we make sedation safe for ourselves and for our patients, and prevent litigation and mitigate any complications that we really don't want. How we apply some of these things and some of the concepts and principles that we can discuss, how we increase our own training, inquiry, experience, and just our own kind of impact and space in that. And then just really emphasizing this word appropriate. What is appropriate, what's appropriate that we should be doing, and how we make sure that we get through it. I'm gonna list a couple of case studies, initially just to tell you what to think about, and then at the end we'll go through it briefly just so that you can have some idea of potentially what my thinking is, and a couple of other sort of people and spaces that are engaged in. Okay, so this is long gone. We know this. In 1987, the American Academy of Pediatrics officially stated that it is not good enough to not control children's pain and anxiety. And until that point, of course, from the 1940s, there were studies done that showed that actually potentially kids didn't really feel pain. We know from that point, and this child, Jeffrey Lawson, was his mother discovered, he had cardiac surgery done in 1985, Pete's cardiac surgery, and his mother discovered that the only agent that he got for his anesthesia was a muscle relaxant. So this kind of prompted the idea that children, especially younger kids more than anything else, have very, very pronounced pain pathways and anxiety sort of spaces, but have a major inability to modulate that pain and specifically inhibit the pain. So we're going to talk a bit about how we actually make sure that just because it's a child, or just because we're busy, or just because it's always the way that it's been done, that is not status quo anymore. Of course, we could just rattle through a whole list of drugs and tell you why each one is great or not so much. That doesn't really help you practically, or knowing what to do or knowing who to choose to potentially do procedures. Two main sources, and just for yourselves, just for your own reading and safety's sake. The first one is, I think, 36 pages long. It was written by Rebecca Gray, who's at Red Cross, and Prof. Rudolph, who is at the University of Western Cape, who's an anaesthetist who does sedation. This is an excellent outline of just how we do things and what we should be doing. And it is written, you know, this is promoted by the Society of Anesthesiologists, but it's specifically for the Society of Sedational Procedures, Procedural Sedation, sorry. And they've got great just outlines and emphasis of safety and emphasis of how we do not do damage. And I really emphasize this point of safety because what has been shown, and there's not very much evidence in pediatric literature, partly because not many people are either admitting that they're doing sedation or because they aren't really, but in adults, the highest number of procedural deaths that happen in hospitals are as a result of out-of-theater procedures. So the bronchoscopy suite, the GIT suite, vascular sort of places, radiology. And it's really a way of us emphasizing that we can do things safer, whether you are in the tertiary quaternary academic hospital or whether you are the only pediatrician working in Polokwane, for example, in the state hospital. So that's the one. And the second one is guidelines published last year by the American Academy of Pediatrics. And they're very similar in terms of their outline and just emphasizing how we do basic things and do them well so that we get things done. So I always think it's a great way of starting. If I had to do something, or if I had to have a drug, or if I had to design a drug, or whatever, what would my ideal be? Where would how would I make it come about and actually get to work properly? So the first one is we want to make sure that what we are giving is quick and predictable. So if I give it reliably, the onset is going to be predictable, the duration of action is going to be predictable, and there's going to be a rapid reversal and rapid return of normal kind of space and state. I want to make sure that it's targeting what I'm trying to do. So is it an amnestic? Is it sedative? Is it an analgesic? Do I need to give individual drugs of that, or do I need to, or is the one drug that I give, two drugs that I give effectively doing that? Is the sedation that I'm going to give allow me to have a successful procedure? So is the patient not going to move when they are going to move? Are they going to potentially feel pain or not feel pain, etc.? Is it safe? And the safety also goes with my understanding of safety. So do I understand what the drug does? Do I understand how to make it as safe as possible? And do I understand how to work it and counter it if there are problems related to it? And then the last one is just a stable clinical picture. So we sometimes think that in a procedure, we're potentially going to change the patient's life. And sometimes we do, and sometimes we don't. The idea is we want to keep the patient exactly where they were before and after. or potentially fix them if we can do that. And essentially the types of sedation and analgesia kind of places that we'll see things are where we might, all of us, pediatricians, anesthetists, analgesic nurses, etc., where we're actually going to see some sort of effect from what we do. The first one is painful procedures. So things that we don't even necessarily think about, we do regularly without any conscience. So lumbar punctures, potentially, intravenous line placement, liver biopsies or biopsies in the ward, which people have told me that they've done readily as peds regs, or I mean, maybe in private it gets done a little bit less, but like that. But those things are still done there. And reduction of fractures, which is an easy one to know that we need to do something about and sort out pain, because otherwise you're never going to reduce the fracture. And then painless procedures. So anything related to radiotherapy or a CT scan that readily the pediatricians are required to go and sedate patients for. I heard a really great example of someone using sedation for genitourinary exams in potentially difficult situations, or potentially just an examination of a patient that you don't want to make overtly more anxious, auditory examinations, etc. So the list is endless. And I think that's a really important thing to note and be aware of. It has to be performed by practitioners who are aware of the complications and risks associated with the drugs that we use and the situations that we're going to find ourselves in. So what is appropriate? We need to find the appropriate patients for the procedure. So that means patients who don't have overt complications, or risk factors, etc. So those patients, for example, would be, in anesthesia, we talk about American Society of Anesthetists classification, and every one of us would have learned it at some point at medical school, maybe even when we did anesthesia as a rotation, as interns. And essentially what it means is healthy patients that are just not healthy, so potentially the asthmatic, but who is super well controlled. Those are the patients we can potentially think, I can do this and I should be doing this in a potentially outpatient setting. Procedures I've mentioned. Appropriate experience. So that's about us making sure that we have the experience to do that. I've said this already, I know. It's just really important for that. Appropriate setting is, are you going to do this in a hospital, or are you going to do this in your rooms? Are you going to do this in the hospital side room, or are you just going to do it at the bed? The point of the setting is that wherever you do it, you have to make sure that you are able to do the procedure safely, sedate the patient safely, allow for the procedure to be done safely, and make sure that the patient is monitored appropriately. Appropriate drug choice, as I said, for the patient, for yourself, acknowledge, and for the procedure. And then appropriate safety, which is, if I have a problem, can I do something about it? Can I get the patient out of this potential problem? How am I going to manage that? And what am I going to do if that happens? So some of you who are parents might feel like this is the ideal dream of sedation. And I have had many, many phone calls from friends who've got children who say, oh, I've got to fly with my child. Is it okay for me to give something, a sedative? If you want to read about it, there's a great article in the Telegraph from last year that actually talks a bit about that and highlights some of those concerns and issues around sedatives. But essentially what we want is anxiety. We want to make sure the child isn't traumatized, especially children who are going to come back for multiple procedures. And anyone shouldn't be traumatized, but especially that. Behavior which is appropriate for us and for the procedure, analgesia if we need to, cooperation, not just from the child, but potentially from the parents as well, who we might need to help us in that state, or might be an addition to the sedation. Safety, and really return to a discharge state. So, the idea of using something which is incredibly long acting, which was something done in the past, is possibly not the best sort of approach and way of thinking through these things now. And shorter acting, more focused drugs are potentially better. So there's a couple of major things which are really important to point out. The first one is just, these are sort of definitions of some sedation practices. First one is simple standard sedation. So if any of us, say, for example, had to go to the gastroenterologist and we had a upper GIT scope in the rooms, essentially it has to be a simple sedation, because unless that person has an anesthetist or someone who's a sedationist there, a single user, so that's what the whole idea is, a single user, someone who's providing it and doing the procedure, can only give one agent. And then it has to be monitored by someone else. So an observer of some sorts, a nurse usually. A single agent can be either oral, transmucosal, so under the tongue, in the nose, or rectal. or inhaled, like nitrous oxide, or titrated midazolam intravenously. And that's specifically only midazolam, no other drug titrated gets that sort of focus. And it is in much lower doses, and you're supposed to give it, wait 5 minutes, and review a response. The dose would be 0.05 milligrams per kilogram, and watch the response. Advanced is any time that we combine drugs.
Yes,
So whether we give
have it on my card.
propofol and ketamine, I just want to quickly ask, sorry, Zenit, whoever that account, please can you guys mute yourselves just for everyone else's benefit as well. Anyways, so sorry about that. Advanced is combination of drugs. If you do anything, if you give an intravenous drug of any other kind, so if it's not midazolam, it becomes advanced. Though a lot of people would argue against that in terms of ketamine specifically, and if you give inhalational anesthesia. So it's not an uncommon practice for people to give sevoflurane via nasal cannulae, especially in smaller children, to be able to give a sedative type effect. And really advanced sedation requires experience. The next one is just briefly, minimal, moderate, and deep sedation. Deep sedation is easy. It's basically a general anesthetic. If a patient gets to a point where they're unresponsive, responsive with much difficulty, they need to have someone who actually can do an anesthetic for them. Minimal and moderate sedation is the kind of realm of where we are working in. So the easiest thing is that minimal and moderate, the patients will have, all of them, they have decreased responses. Minimal is great because it just means that they're asleep, and as soon as you speak to them, they'll wake up. No issues with airway breathing or cardiovascular type responses. Moderate, if you purposefully speak to them or light touch, they'll wake up, but still no support really needed. And deep is they're not easily arousable. They need airway support. They may need respiratory support, and they potentially need some sort of cardiovascular support, but not, that should not really be happening too much. Sorry, one other thing I just want to say about that is the main thing is with minimal sedation, you need minimal monitoring. So all of these patients require monitoring. They'll all require levels of some sort of intervention, but as you increase in your levels, so your monitoring has to go from intermittent to continuous. You have to assess all these patients well. So the easiest way of asking is, has the child ever had any other sedation before? Is there any kind of past medical history? And especially with asthma, are there any complications and allergies related to that? And that immediately just changes your status in terms of what the outcome is. Patients who go up the list of complications increase their risk of complications from sedation up to three times. So literally just going from an ASA status 2, which is like, as I said, patient with some kind of comorbidity, but very well controlled, to an ASA status 3, where there's some sort of complication, but controlled, increases your risk of complications threefold. A current upper respiratory tract infection is a major restriction of that outcome. You need to do a good physical examination. Sorry, I was muted. Yeah, a good physical examination to ensure that there's no other complications related to obstructive sleep apnea type things. And as I said, those are sort of the basics of monitoring. You definitely don't need to be doing all of that stuff. The basics are heart rate, saturations, blood pressure intermittently. If the patient has any other risk factors, you start doing ECGs, and the ideal is to use capnography, which is not always possible. And a lot of it is clinical, so watching the patient, watching them breathe. The other thing that people are really concerned about, legitimately and justifiably, is our fasting guidelines. So there are very many things. Basically, if you're going to do simple sedation, so anything where you give a single agent without any issues, you don't have to fast the patient. And that is in the guidelines from the Society of Sedationists in South Africa. What has changed, however, is if you are going to be doing more complicated sedation, which is potentially what all of us would be doing with some experience, the international guidelines have changed, and we do not want to unnecessarily starve children at all. So clear fluids is anything that you can pick up and you can see through. So the younger kids and parents love to give their kids rooibos tea. That is absolutely fine as long as there's no milk in it. Breast milk has 4 hours of starvation before the time. And so any solid food, any formula, anything else is about 6 hours before. So it's really important to plan it well if you're going to do a procedure and make sure that the kids are not starved. So the 3 cases. First one is a 7-year-old boy who is morbidly obese. He has an upper respiratory tract infection. He's had no previous anesthetic or sedation. He fell off his bicycle and he now has a supracondylar fracture, which needs, which can be reduced. Yeah. Second one is an 11-month-old girl who's had a blunt head trauma. Her mother tripped over the dog. There's nothing sinister in the story. There's no base of skull fracture. The GCS is decreased. The child's a little bit irritable and ratty. You've done an ultrasound and you feel that you need to do a CT brain and the child needs sedation. Third one is a very different sort of situation. A 3-month-old boy who comes in very sick, not well, mottled, lethargic, heart rate of 190, temperature 39.5. Parents say there's no overt source of sepsis. There's nothing else that's sort of been going on. They do, however, acknowledge that he has not been immunized. You put an intraosseous line in, you give fluids, you stabilize the child, you get an intravenous line in that space, and you decide that you want to do a lumbar puncture on this child. And that's obviously an extreme situation of that. So my thoughts, the thing I pose to you is, what would you do in these? So there's pharmacological and non-pharmacological approaches. And Angie's going to talk a bit about the non-pharmacological approaches. The main thing is that every single one of these situations has to be tailored to the parent, the child, and the facility. And the facility means either your experience in it or kind of what the people around you know how to monitor and know how to work. And that's really important. It gives, all of this ensures that you have decreased fear, decreased anxiety, and decreased parental discord, which especially people that work in, I'd say private practice, but kind of everywhere. Every parent has a right to be able to know and understand what's going on with their child, and has a right almost sometimes to be moderately difficult. Moderately. So, first one in the non-pharmacological. Should parents be present for procedures? And that's something that all of us deal with. I deal with it when I put a patient to sleep. You may all deal with it when you put up intravenous lines, or when you do a lumbar puncture, or you do any other kind of invasive procedure. The main thing to note, and this is from a really great study that was done, published in 2018 in anesthesia literature, but there are a myriad of other studies related to these sorts of things. Midazolam is better than a parent. A parent who is anxious is worse than anything else. A parent plus midazolam is better than a parent alone. So if you can get a parent who is cooperative, willing, wanting to be there and supportive of the child, that is an excellent adage to the entire process. Drugs, and there's many. So many of you will know a myriad of other drugs. And I emphasize these because they are easy and they're easily available and they're actually really cheap. So sucrose, excellent for under 3 months old. Midazolam, easy, and you can give it in multiple different routes. Ketamine, fantastic because it's mostly really safe. It is really safe, especially if you use it in single agent type spaces. Opioids, they become much more problematic, but a lot of, especially like pediatricians, emergency services, etc., physicians are really used to giving, or sedative type things, very used to giving morphine. And usually midazolam with it. Alpha-2 agonists, and some of these sound like a bit of, some people are a little bit hesitant and a little bit like airy-fairy about the alpha-2 agonists. So specifically, I mean clonidine and dexmedetomidine. Propofol, which I know that not everyone is au fait with, and potentially you may have used it just when you intubate patients. And I'm not going to touch on that too much, and that because that really comes into the realm of just understanding the drug and using it safely. And then the importance of EMLO, and not underrating that sort of thing. So what do we have? Sucrose is easily available. It is in a formulation, it will be available in any of your hospitals. It is safe to use. You give it to children, especially less than 3 months, and it has an analgesic effect and a sedative type effect. It is fantastic for short procedures. It's fantastic for procedures like lumbar punctures, CT scans, and even MRI scans. That's great. A child with nitrous is also potentially really great and easy for short, painful procedures. The nitrous nitrous has become controversial in a few ways. The first one is giving nitrous to children who are under 3 or 4 years old, and there's a whole lot of stuff and discussions around neurodevelopmental delay or concerns. But potentially a child who is over 5 years old is having a specific procedure, so like an intravenous line sighted, a lumbar puncture done, maybe even a reduction of a forearm fracture. Any of those kinds of procedures work fantastically in a child who's got nitrous. I know that there's a lot of concern, especially inland and at high altitudes with nitrous. The idea is to increase the concentration relatively of the nitrous oxide to the oxygen and possibly use it as an adjunct. But especially at the coast, nitrous, at least 50-50. So 50% nitrous, 50% oxygen, Internox, which is available all over the place and is actually standard drug availability, is great. The ones that become slightly more problematic, but actually also really easy to use, are Dormicum or Midazolam, which come as IV formulation and oral formulation, and can really be used in any, as I said, oral, transmucosal, intravenous, even rectal. The main difference is what their onset is and what their duration of action is. And that's really a big thing, because if you want something to work really rapidly, you need the child sedated really rapidly. That's what you need to ensure that you have. And ketamine as well is something which is, someone mentioned to me recently, oh, there's a lot of concern because ketamine potentially causes depression. And both ketamine and the alpha-2 agonists, which I haven't mentioned now, are, clonidine specifically, are very free of respiratory depressive effects, except when they're combined with other drugs. And that's really a problem. So it's about using in simplest ways and ensuring that those are given appropriately and sufficiently before. The last thing I just want to touch on in terms of this, and I know I haven't given you doses, but I have a list and I'm going to send it with an easy thing of appropriate things which also require training. Emla cream is something which is supposed to be available freely and readily. It goes in and out of the drug formulary in terms of availability, especially in state. It is something which, I looked online earlier and the Dischem apparently it costs 400 Rand for a tube like that. The main problem with Emla cream is time to onset. So applying it is great, but you have to give at least 30 to 60 minutes for it to have a decent effect. That obviously doesn't work in an emergency situation. And in the US, North America specifically, they have topical lidocaine, lidocaine, which works fantastically. We have that, but we don't necessarily have it in the same formulation as they do. Literally, they can apply it, and within 5 to 7 minutes, it works. Emla is really great if you are trying to, especially a child who comes back from multiple things, like the oncology child or a neuro child or something where they are going to be poked multiple times and you want to take that pain away. There's some concern about Emla and methemoglobinemia, especially in neonates, and that has mostly been debunked, especially if you're using it within a dose which is appropriate. Emla needs to be applied, needs to be occluded with the dressing and left on for 30 to 60 minutes for it to have an effect. If in doubt, do not be afraid to call the anaesthetist. And this picture, I could not find a better picture. This did the rounds recently, like the anaesthetist who looks, I know some of us are very scary and some of us don't really like leaving the shelter of our haven of theatre to come and help. But if you are in doubt and if you feel that there's an unsafe situation or you're not sure about sedating a child, call the anaesthetist and ask for help. In private, it's easy. I know that in the state, it sounds like a near impossibility. And some of my friends in Joburg specifically have said that that's a difficult ask. Just important tips for parents: remind them before they come to hospital, before they have a procedure done with you, that bring distracting things. So iPads, laptops, iPhones, fancy devices. South Africa has the 7th highest ownership of smartphones in the world. Things that are comforting, like blankets or pacifiers or something. Reinforcers, toys, anything that makes them just feel calm and normal in life when they come to hospital or when they're going to have a procedure done or when they're going to be in your rooms or wherever. Tablets have been shown specifically to be a fantastic means of reducing anxiety specifically. So it is probably as effective as a pre-med with midazolam, but it also requires someone to use it until that point and to actually ensure that you are encouraging the patient the parent to be using it with the child. So I'm going to go through this briefly, just sort of in closing. Yeah, so a 7-year-old boy, morbidly obese. So the one problem with that is this child almost invariably has obstructive sleep apnea, which means that every single one of the normal drugs that we would give is potentially going to cause some sort of increased risk of respiratory depression and complications. He's also had an upper respiratory tract infection recently, which means that his risk of respiratory complications, so apnea, obstructed breathing, and laryngospasm, is dramatically increased. He's never had anesthesia or sedation before, and that's fine. Yeah, but he has to have this fracture reduced. So our options are obviously we can take him to theatre for a general anesthetic, or we could do this safely in a room, in a casualty type space. If you're sitting in a room with people, you can discuss briefly. I'm going to tell you what I would do. So the first thing is, in any painful situation, make sure that your basic analgesia is done well. So what does that mean? In this patient, I'm going to make sure that this child has paracetamol, a decent dose of it, so 20 milligrams per kilogram. And I'm going to make sure that this child has ibuprofen, or one of the non-steroidals, to ensure that at least I'm on top of the pain in that sense. I'm going to give this time. This is not an urgent life or limb thing, but it does need to be done imminently. Your options are midazolam, very unpredictable in patients with very unpredictable in patients with obstructive sleep apnea. An intravenous opioid, intranasal opioid, so fentanyl intranasally. The other one that is a fantastic agent to use here, 2 agents, either ketamine, and that can be given intravenously, intramuscularly, which sounds cruel, but it actually works really well, especially with EMLA applied, or orally in higher doses. So the intramuscular and the oral doses are higher than the intravenous doses, which are much lower than we actually thought before. Or clonidine. And clonidine, a really decent dose, so between 1 and 5 micrograms per kilogram, and you have to give clonidine at least 30 minutes to work, almost 60 minutes to actually have a decent effect. And with that, you probably will be able to reduce the fracture, and you are very unlikely to have apnea and respiratory tract complications. The blunt head trauma, the child has to have a CT scan. The child is unruly, very difficult to kind of control, etc. If the child didn't have a decreased GCS, the ideal thing, and we know CT scans are very quick, especially for this kind of thing. They don't need contrast, usually, potentially not. And so quick, and distraction techniques work really well if the parents are motivated. This is a different situation. This is probably not going to work that well. So our options, and probably the best options that we have, are ketamine, which does not increase and change intracranial pressure as we once thought, or midazolam. And in this situation, intranasal midazolam at a slightly higher dose of 1 to 2 micrograms per kilogram it will work within 5 to 7 minutes. You'll be able to do the scan. The child will be somewhat sedated afterwards, but they'll recover relatively quickly. The last one, a child who needs an LP who's incredibly sick. Now you've stabilized the child. You don't want the child screaming and triggering all of this again. So the problem is that a 3-month-old, the most useful thing is probably to give them sucrose. As I said, if it was an elective lumbar puncture, EMLA cream is great if you're in the US. Lignocaine cream is great, but we don't have that here. My point is that, and there's a lot of great evidence showing that despite what we thought and despite what we think, and that let me just do the lumbar puncture, quicker, easier, done, or it obstructs the view, etc. Your success rate is dramatically improved if you give the child some sort of sedative, potentially, and if you give local anesthetic into the area. We would never dream of doing a lumbar puncture in adults without giving lignocaine into the area, quick, easy. So there's very easy ways of us getting around that in kids and actually having them not hate us when we do these types of things to them. So the future, there's a growing need for this. There's a growing need for sedation being done, and not just because discovery mandates, I want to say discovery, but not just that medical aid's mandated because it's cheaper for them, they don't have to pay hospital bills. There's growing evidence of better options and much more research being done, because this is a field which has not been going on for very long in as controlled a way as it is now. We need to look at the short-term effects, and there are some great studies being done. I mean, there's some great stuff that's done with anesthetic specifically when we send kids home and seeing what they're like in the first couple of weeks post a procedure. And kids are often, they're actually like edgy and not okay, and their parents, there's a little bit of regression of attitude and milestones and that, and then it's not going to cause any long-term complications, but we want to know the same sort of thing for sedatives. And then this discussion between neurodevelopmental issues, especially with ketamine and nitrous. But at the same time, a child who is incredibly anxious and screaming in pain is going to also have multiple issues longer term. So it's a bit of a way up. And just in conclusion, I really dislike it. It's one of the most frustrating things, I'm sure you all experience as well, is when a child specifically comes to have a procedure done and you ask them what's happening and they have absolutely no idea because the parents are like, no, don't tell them. So the same in this kind of sense. As long as we are doing stuff which is straight down the line, we are honest with patients and we get them to buy in, we're actually going to have a very successful process of being able to sedate analgesics and get procedures done in patients. Thanks.
Thank you, Dean. Wonderful. I see there's already a question for you. And there's a question from Mark Patterson asking about should sucrose be diluted in water or just granulated? And how long do you wait before it works?
So sucrose works incredibly quickly. It's a fantastic agent because you actually just give it as it is. I have just lost the, oh wait, here we go. Yeah, so it works literally within minutes. And yeah, it's great for especially like up to 3 months, but in preterm infants. And then the dosing is, so there isn't actually an optimal dose, but the range is kind of, I mean, they use grams, but essentially it's like 0.1 mils for a 24-week post-gestational age, up to 2 mils for a 3-month-old child. Yeah. Minutes, so minutes. It's like, if you want to do a procedure with it, you take them in, you get them, you start getting them comfortable, you give them the sucrose and they fall asleep amazingly quickly. It's not expensive. Sorry, the one other thing that I also wanted to say about ketamine specifically, because this is the, I think for a long, it was expensive. Ketamine was very expensive for each vial. I checked today. So if you work in state, it is 33 Rand for the 20 ml, 10 milligram per ml vial, and it is 38 or 39 Rand for the 50 milligram per ml vial. It's not even double that in private. It's like 60 or 70 Rand per vial in private as well. So it's not like a 400 Rand vial of drug that should put you off using it. That's, yeah. And sucrose is also cheap, and you must chuck the bottle away once it's been used, unfortunately.
Okay, thank you, Dean. I think we're going to move on to Sister Angie Skrikker, who is going to talk to us about complementary aspects of pain management. Dean, I'm just going to ask you to stop sharing. That's fantastic. And then I'm going to share the screen here. And we're going to hand it over to Angie. Can you guys all see the screen? Good. Oh, thank you, Angie.
Good afternoon, everybody. What an honor to be here today and just talk about the non-pharmacological aspects of pain or complementary medicine. It is absolutely amazing how this is still a challenge today, and sorry, here we go. How it's still a challenge today, and the barriers to pain management is still real. And even today, we're in the 20th century, and yet we still argue about prioritizing pain management, and yet pain is throughout all the spheres of medical, nursing approaches and stances that we get. Is there solutions? Absolutely. Do we sometimes have a challenge with it? Yes. But is it right in our face? That is also a yes. This is just a beautiful picture about how we can make our environments therapeutic. In this state, it might be a challenge, but it is still something that we can do. One of the most common reasons why children come to the hospital, or the first indication of something is going wrong in their bodies, is basically having pain. And children do experience severe pain, and yet it is still underestimated. and undertreated in the health sector. Touch, still a very important thing that we need to do, and yet this also becomes a challenge. So why are we saying that pain management is still challenging today? We look at the knowledge. There's still a lack of knowledge today in both nursing and medical. Training in pain management is still one of the things that's not really happening in the nursing curriculums or in medicine. But we do have beautiful courses at UCT. We have one that is called the Interdisciplinary Pain Management course, and that is at postgrad level. So we would love to see that we get this in undergrad level. Then we know we're getting there. We still are challenged with attitudes and beliefs, desensitization, and especially now during this period in 2020, compassion fatigue is just something that was really real in the health sector. There's low expectations from families coming in with their children in pain. As long as they get Panado, they're happy. And then sometimes from the health care worker, there's low expectations. I only have Panado and Brufen available. So that is what I will give. And we're not thinking about the fact that we can access Valeron, we can access morphine. There's more that we can give. Is there a possibility of the other drugs? And we just don't want to go through it because then we get blocked by the system and the lack of resources again. We have the clinical guidelines and protocols, and I'm always amazed at how research is developing. And yes, there is a plasticity in pain research, but more so in pediatric pain. And yet the protocols and the guidelines that is available becomes one of the documents that's just locked in a drawer or hidden on a computer and not really revisited on a regular basis. So do we use pain scales? Is it available? Absolutely available. The question is, are we actually using it? Are we checking? Is there a document in the nursing process that speaks about our pain scales? Is the doctor on his round asking the team, what is the child's pain today? Which pain scale did you use? And sadly, in many cases, that is not part of the routine questions. This I want to, this we see mostly in the clinical settings, but we also see it in hospitals where we're thinking about this child is too young. Are they not exaggerating again? Is the mother not maybe enabling the child too much? My clinic is busy, my ward is busy, I've got 35 patients to look after. I do not have time for this one child today that is maybe in pain. And sometimes it's just one out of your 30 patients that is in extreme pain, that needs that extra attention that we tend to think about. I don't have time for this. And I was just reminded of this in the week where I was told, Sister Skrikker, not now. We have a big clinic. We cannot allow the child today to take control. So those are the, and what was the end result? We will get to that, but it was extreme anxiety and poor pain control. So why should we prioritize? So there's your physiological responses that we need to be aware of, your psychological responses. How does it impact the child and the family, including the health sector economically? What is social? Do children have a social life? Absolutely, we just forget about that. Is there legal implications, and is it even ethical to look after pain? With our physiological responses, we know that when our children is in pain, that they will have maybe increased heart rate, change in their saturation. We also see them having change in their respiration. And many times, for me, the main one that I always see is the excessive sweat. And in Afrikaans, we used to say, drywe korrels. And translating that is just not going to come out right. But the psychological effects of pain is also something that we can never dismiss. one of the first things the mother will tell you is this child never slept last night. I never slept last night. And then we get stuck on what the mom is saying. I never slept last night. And we forget that mommy actually also said the child never slept last night. And we want to get agitated and annoyed with the mother because, again, it's a difficult mom standing in front of us. But if a child is sleeping poorly and is waking up screaming in pain day or night, we need to pay attention. Because the next thing that we will see is repetitive pain, and poor pain control can lead to PTSD, trauma over and over of the same thing. And do we see that in reality? Do we see it in practice? Absolutely. It is also quite evident that when the anxiety levels of a child is heightened, the pain is also heightened. And when that child expresses severe pain, it becomes quite tricky. Is this now pain or is it anxiety? And we tend to want to say only pain and not acknowledge that the child is also anxious and fearful and have fear-related responses to the pain. And one of the things we see when children are known to certain procedures, how they go, and they have anticipatory anxiety, and starts crying before they enter the procedure room or go to doctor's clinic. Typical examples is your dentist and your burns clinics and any other clinic out there where procedures is happening. And what happens when pain do not, as time goes by, when pain is not treated well in the first instance, we're going to sit with all these things that I've listed: sleep, PTSD, anxiety, and depression. But if we can break that cycle, we can avoid depression. But if we don't break that cycle, we will see depression in children. And we are so fortunate at Red Cross to really have a psychological team that can work with us in pain management to just prevent or get depression when it starts before it becomes full-blown in children. So how does it impact the child socially? Children go to school, that is where they live, that is where their friends are. And suddenly when they have pain and the pain does not go away because they can't run as fast as the other child because their foot is sore, they start to stay at home. I can't kick the ball properly, sister. They laughed at me when I played soccer because I could not bend my body properly. You know, I hear those stories from children. Then they start to isolate themselves and hide inside the house. Then they sit in front of a TV the whole day and they start to just disappear from the norm of what the child is supposed to do. And you find the mother coming to the hospital over and over again, visiting the doctor over and over again. And again, the impact on the family and the siblings, it is enormous because suddenly everybody's focus is on the child in pain and the rest of the siblings is watching and not getting their attention. And what does that do to their relationship in the future? How does this impact the family completely? We see how households needs to go for group counseling, family counseling, simply because of one child in pain. Do pain have any legal and ethical ramifications? Absolutely. We know pain today is a human right. We also know that no one shall be subject to inhumane or degrading treatment when they come to us for help. And when we look at the ethical things about negligence, we do not want to be the doctor or the nurse or any healthcare worker or allied worker that's going to be faced with unreasonable failure to take an adequate history of pain, unreasonable failure to adequately treat pain. And that for me is so important. And then a simple thing that we can do, because we all have our limits, is to call for help. I'm a professional nurse. I do pain management at Red Cross Hospital, but I do not look after the primary cause of the child that's in the hospital. So if the child has come in, for example, for an appendectomy, and the child's pain is still there, yes, I'm going to touch and palpate the abdomen, and I'm going to notice that it is tense. My job is to inform the primary team that that is happening. They will take over. And I need to inform them, Mom, we're looking at the pain. Yes, I agree with you that the tummy feels a little bit tense. Let's speak to the surgeon and hear what is happening. And do you know how beautifully, as a nurse, we can work alongside our colleagues, the doctors? It's absolutely amazing if we just have the courage and the knowledge to do so. How does it impact the family, the child, and a hospital economically? Increased complications, longer stay in the hospital, more doctor visits. And we all know we live in a country where we have children and families that are exceptionally poor. We know that families come to the hospital and they come with their last 50 Rand or 20 Rand and do not even have money for food, but they will come. This child must get a sick certificate and no sick certificate is ready in the notes. The mother must come back just for a sick certificate. That is also how this just play on the economic status of a family. And then what about their jobs? People are getting paid per day for their jobs. Some is not as fortunate as others to have a regular salary every month. And some of them are just working and getting any job they can get. And yet we are saying, please come again. How can we synchronize this? Or how can we make it better for families economically? How can we treat pain better and make sure that if you don't know, we pick up the phone and ask an expert so that we can reduce the burden of the economy in our family lives. A simple way to do things once your child is in the hospital is to prepare the child. Explain to the child what you need to do, why you need to do it, why is it important. They have a lot of whys and we get tired of those whys. By the moment the child knows and understands what is happening, everything changes. The child becomes more cooperative. The child is maybe still scared and is anticipating pain, but is more willing. The child is trusting you. And why don't we ask them, can I touch your body? I need to touch your abdomen. Why? When they come to us, they're already powerless. And we can use imagery, we can use play to demonstrate. Simple things that we can do easily out there for us. Prepare the caregiver. This is the mom, the aunt, the grandma, the dad, whosoever came with the child. Tell them what is going to happen. The moment you reduce the anxiety of the caregiver, you've won half the battle. 50% of your work is done because the child still looks to his parent for affirmation. If he sees anxiety there, worry there, mommy's crying for me, he's going to cry with her. But if he sees mommy is trusting this healthcare worker, she's understanding and she's repeating to me in our language that we speak, what is going to happen to me, this child becomes calm and becomes more cooperative. Our environment, that is self-explanatory. We know we need to have a clean environment. There's nothing as bad as walking into a room and a swab is under the bed. Our monitors needs to be in working orders. We can't realize when the child is now going to have a SATS monitor on that the SATS monitor is not working or that it's not clean. Let us know our equipment and let us have our consumables available. And then do we need a support team? And before we get to the support team, you know, I love goals. And when we do goals, I always do it very simply. And I do it with the family. So you have your goals as the healthcare worker, the child and the family have their goals. And then you ask them, is this goal specific? Is it measurable? Will you be able to achieve it? Is it realistic? And can you do it within a time frame? And sometimes you need to take that goal that they have. They might have a goal that is too big to achieve, and you would be able to see that. You can help them to reduce that goal and make it manageable for them. And if you do intend to do a sedation, do you have a plan? Do you know what your drugs, and do you understand what you are going to do? Do you have somebody else, a consultant that you can call on? And what is your bailout strategy going to be? Are you going to have a little team discussion before we call it quits? Or are we going to say, today the sedation didn't work, but we maybe need to think about general surgery? So those are the things we need to think about. Today, you weren't able to walk properly, but we need to put a plan in place for you to start bearing weight in order for you to walk again. And that is now for a child to have pain of his one of his limbs. So those are the things we need to think about when it comes to how we manage children in pain. We need to be mindful that we have biological, psychological, and social factors that always influence pain. If I just quickly run to social factors, then I'm just thinking about culture, boys don't cry. And my son says the new phrase they're doing, he's only 13 years old, is like, you need to man up. So those are the things how children talk out there. They have their own little language. We also need to remember also, sometimes we need to coach mom and dad as to how they need to do things, because children learn from their families. And then we need to look at fear, previous experiences of pain. Take a good history. Know what is happening in this child's life so that you do not have these psychological factors and get it exacerbated over time. What is the biological factors? We need to do things according to the child's age. We need to tailor our treatment. We need to make sure that it is developmentally appropriate. And we need to be cognizant of the fact that every child is different. No two of them are the same. So we are basically saying in pain management, a pain assessment is also important. Take a pain history. Yes, you've read the folder, you've heard mommy saying what is the pain history, but did you ask the child? What is his perception of his pain history? Do you understand what is a pain tool? Are you using a pain tool? Is it necessary? Do you record what you are writing? Do you read it back to the family and make sure that what you are recording is the correct information? Do you understand what is mild, moderate to severe pain? I will show a slide later on where we just have a beautiful picture where it shows mild, moderate to severe pain, so I'm not going to go into it. And then interventions, that's number 2. You have your pharmacological approach and you have your non-pharmacological approach, and please don't forget your goals. And when you look at your medication for pain that you're giving, remember always to titrate it according to the child's pain behavior. Just because the child have a good night's sleep and his pain is under control for one day, doesn't mean the next day you need to go down and titrate it. Institute appropriate monitoring and observation, and always do a reassessment. Check, mommy, did the pain improve? I'm just going to use this name because it's my son's name. Joss, is your pain better? Ask the child. Or is it the same? Sometimes the parent and the child have a different understanding of what is happening. And sometimes the parent becomes the soundboard of the child and the child will not speak to you. Then listen to what mom is saying, because he's telling mommy, Angie is coming again tomorrow. Mommy, I want to tell her my pain is still bad. It's not improving. I still feel the pain. Then listen to that. The third day, he's going to open up and maybe say to you, Angie, I'm better today. And then ongoing management, have a plan. If you notice that this child's pain is going to span over a period of time, do prescribe medication that this child needs, but do advise. Do advise them on deep breathing exercises. Do advise them on simple things, going for a walk, going for a run. Simple things that we can do to make a child's pain better. And that is why the history is so important. What we've done at Red Cross, we've incorporated our pain into the PEWS chart. And do we find it a challenge for people to report and record pain? Absolutely. Is it something that can be improved? Yes. But is there a greater awareness of pain now that pain is incorporated into the PEWS? The answer is yes again. Because pain is also an indicator, just like all these other physiological signs that we are always looking at as nurses and as clinicians, pain is also telling us something is happening in this child's body. So with your pain history, it's always important for you to know that you need to ask the correct question always. And it's always important to use the language of the child. Some children, like your smaller kids, only know the word sore. I'm sore. You ask him, do you have pain? I'm sore. That child only knows that word. When he's a little bit older, he's now maybe 3, 4 years old, now he's saying, I'm sore and my tummy is sore. Now he's 6, 7 years old, I'm sore and it's a stabbing pain and my tummy is sore. And now you get to the older child, the adolescent, and he just looks at you because he really don't have time to talk to you. He's already mad that he needs to be in the hospital. That child, you really need to engage and find out, how can I make it interesting for this child to tell me what is happening to him? So it's important to be developmentally appropriate and to remember that every child is an individual. Check the history. What is happening with the child medically? What is happening with the child in his with pain? And always ask your colleagues that have seen the child before. Just check. Are we understanding the same story here? Is there something else going on? What does it do in his own life? Does it impact on activity? Does it impact on play? Does it impact on his schooling? Does the pain impact on his daily activities? What is the relieving and aggravating factors? The mom will be able to assist you with that. She would say, if I massage him gently, his pain is better. But if I touch their sister, it hurts him. If he lies on his side, it's even worse. So those are the things that we really need to know. What is important for us also is to understand, how do we measure our pain? Do we understand that 8 to 10 means severe pain? The golden rule is still that self-report of pain, especially with your older children. And your behavioral indicators is really just how the child behaves. Is he becoming isolated? Is he becoming guarded? Is he not allowing you to touch him? And what is the physiological indicators? What is his body telling you when you do those measurements? And sometimes one tool is not enough. You can use the FLAC scale and self-report. You can use the neonatal infant pain scale, and then you can check at what is mommy saying about this child. So don't be scared to use things in conjunction. So this is the tool I spoke about earlier, which is just basically a pain assessment tool. What I like about this, it reminds me of the older kids. So when it comes to severe pain, they are like, you know what, my pain is 100%. It's 100 out of 10. And I remember in D1, the assistant nurse asked me, Sister Angie, must I now write 100 out of 10? You don't get 100 out of 10. I asked her, did he say that? And she's like, yes, he said that. And what does that mean to him? Did we find out? And he's like, I'm dying here. You know, I'm dying of pain. I don't even want to talk about this anymore. So yes, this tool, I love it. And I think it really helps us to understand what does it mean. And it also helps the child to understand what does it mean. So there's many pain scales. I love the FLAC. We use the FLAC in the hospital. We use the revised FLAC scale. We use the FACES scale. And the revised FACES scale, we use the neonatal infant pain scale. So that is just because we're looking at the different developmental stages the children is in, and also at the different age groups. And look at that, VR is a beautiful thing. It really works if you've explained what they should be expecting and what is going to happen. Thus, non-pharmacological strategies is beautiful. So contextual measures, I always wonder about this. Can we not cluster our procedures to avoid overhandling of any child in the hospital? Can we not do the HP and the blood glucose at the same time? Can we not do all? But now what do we see? One come and do the HP at 8 o'clock, another one come and do the blood glucose at 10 o'clock. And oh yes, we forgot we needed to put in a drip. And then the intravenous excess is done at 12 o'clock because we suddenly remember the child is going to theater tomorrow. and that is so unnecessary. Reduce to the noise levels, that is important, because we do get sensitive when we're in pain. Dim the lights and be aware of this soothing smells. And sometimes you get smells that's not so nice, and that is also something that you can address, and you can maybe explain, maybe because of the stage where the wound is at, the child is having an infection and therefore the child is not smelling nice. Breastfeeding, when you maybe do a vaccination of a child. The dummy, why not ask a mother, are you breastfeeding, yes or no? Should we use a dummy, a bottle? How can we assist you? Cognitive measures is again, explain the procedures, do reassurance, know that you can add mindfulness, you can refer the child for yoga, provide distraction if there is no distraction, encourage the child to bring his favorite toy, music therapy, and also to bring maybe his tablet, his cell phone. It is in any way in the hospital, so you might as well use it. Emotional support, the presence of the caregiver cannot be, it's very important. You can use the caregiver to your advantage. Use is not the right word, but they can be your assistant. So if you do structural parental involvement, it means you're simply asking and telling the parent what you need them to do. It's also important to remember that when you are working in a team, one person speaks to the child and the mom. All the other voices is just going to make a noise and the child is going to get confused. And do use a calm, soothing tone. Active reassurance, positive affirmation, praise and reward systems. It just goes very, very far. And it can be as simple as a piece of paper and you're drawing stars, 1 star because you did that and a 2nd star. The environment, I've said it already, it should be clean and all your monitors should be working. This is just a pic of what we are talking about. And then in summary, pain management must be a priority. Treat it according to the severity of the pain. Use pharmacological, non-pharmacological, multimodal analgesics, and as far as possible, avoid PRN dosing. Atul Gawande said, it better is possible. It does not take a genius. It takes diligence. It takes moral clarity. It takes ingenuity. And above all, it takes a willingness to try. Thank you very much.
Okay, thank you, Angie. Let's see, is there any slide, any questions from the audience? I don't know if you want to type any questions in the chat box. Let's give a bit of time for questions coming forward. I'm going to maybe just ask Dean while we're waiting for more questions to come in. You mentioned in your case studies that you gave the first patient with a fracture to use NSAIDs. Where are we with NSAIDs at this stage in orthopedics and fractures?
So that's a great question. Basically, it's only in orthopedic literature that there's a feeling that they potentially decrease wound healing, but it's not. It's a very, very iffy sort of statement. So the problem in like a lot of the pain literature is that having pain is going to decrease your wound healing, and decrease recovery and all of that on one hand. But the orthopods, it's an older thought that because it blocks inflammation, you're potentially going to decrease the actual wound process and decrease the bone manipulation and stuff. So there's 2 parts. The first one, someone might argue that because the child has asthma, you shouldn't give it. That's very old, and that's almost redundant. And the second part is exactly that. Like the orthopods might say that, but it's definitely more beneficial to give it than not, especially in this child that you really do not want to give any kind of opioid containing substance to try and get it. That would be the balance of risk. Yeah.
And then also, you often hear people are afraid of using opioids, morphine, because of respiratory depression. What would you suggest would be safe dosages to use in children in a ward situation where you don't have monitoring the whole time on? When would you start worrying about respiratory issues?
So there's three parts to it. The first one is looking at the child itself, so acknowledging which children should and shouldn't get it. The second one is there is a point where you should not be giving it because of lack of monitoring. And the third one is exactly like you're saying, what can we give safely? So any child who has risk factors of obstructive sleep apnea, which we're not always great at acknowledging. Children have much higher incidence of it than adults. And basically any children that have got dysmorphic type features have a much higher risk of that. So the biggest problem with obstructive sleep apnea is that they're not as, there's lots of issues, but one of the main problems with opioids, benzodiazepines, a couple of other drugs is that they're not as responsive to the CO2 effects of those drugs. And the sedative / respiratory depressant effects are much higher. So that children under 1 year old, 2 years old, very iffy doing that in a general ward situation. The second thing is if you need to give it because the pain is severe, Angie said it, the first one is get the basic stuff right. So make sure that, and this is with any kind of pain response, give as much of the good stuff as you can so that when you're giving the opioids, you reduce the total dose. And then the third one is safest things in the wards are oral morphine. And the second one is Valeron or Tilidine. And Valeron dosing is actually super easy. You can't use the patient's actual weight, especially in obese patients, because you're going to overdose them. So it's 1 milligram per kilogram, 1 drop for every 2.5 kilograms. And then you kind of up it from there. And that you can give, the first one is give the basic stuff regularly and then give those things regularly as well. So every 4 to 6 hours, give it. So yeah. So I know that it doesn't give you like an easy out. It doesn't say, okay, cool, give some IV morphine. Or, I mean, IV morphine is terrible in children, especially. But yeah, and then I mean, there's like new things like fentanyl patches. Yeah. The other option, which is not bad, is fentanyl intranasally, but you still have to know that the child isn't going to have a counter effect to that, and they still have to be watched in that first part of post procedure in any case.
Thank you, Dean. I see we don't have other questions coming through from our audience, so I think I'm going to thank our speakers. Dean, thank you very much, all the way from Gauteng. Seems like you had a busy day, so thank you for being available to help us out and talk us through some procedural aspects. And I think the 2 documents that you put on, especially the one from the Anaesthetic Society on procedural sedation in children, is very important for us as pediatricians. And Angie sitting next to me, thank you. She had to rush in to get her kid from school, but thank you for being back here and sharing all your valuable experience with us, looking at adjunct stuff in pain management. Thank you everybody for signing in, and have a good evening. Goodbye from all the SAPA executives.